The ASHP Research and Education Foundation, in partnership with the Cardinal Health Foundation, is pleased to present the 2010 Award for Excellence in Medication Use Safety. This award, the only one of its kind, honors pharmacists who exercise leadership that results in multidisciplinary teamwork, innovation, and improved patient safety within a medication use system in a hospital or health system. Our first finalist, Lancaster General Health, has served the needs of its community for more than a century, growing from a small city hospital to a major regional institution. In 2006, as part of ongoing efforts to reduce medication errors, the hospital instituted a program to increase connectivity between systems used to order and administer intravenous medications. While the hospital already used intelligent infusion devices, barcode medication administration, and electronic medical records, the technology was sometimes being used independently, minimizing its effectiveness in preventing medication errors. Over a 3-year period, a pharmacist-led multidisciplinary team built and implemented an IV interoperability system. With the new interconnected system, pharmacists review physician orders for IV medications and enter these orders into the pharmacy information system. The pharmacy system then communicates with the barcode system at the patient's bedside to ensure that crucial information is confirmed: the patient's name, medication, dosing, route, and time. The barcode system then communicates with the pump that infuses medication to the patient. The IV interoperability pilot yielded impressive results. A more than 70% decrease in situations where an error could occur during programming, and a 32% reduction in ADEs involving unfractionated heparin and pump programming. For its pioneering work in implementing IV interoperability with pharmacist oversight, Lancaster General Health is being honored by the ASHP Foundation as a finalist for the 2010 Award for Excellence in Medication Use Safety. Our second finalist, Kingsbrook Jewish Medical Center, serves a large and diverse patient population, many with critical illnesses. As part of its ongoing effort to improve patient care, the staff at Kingsbrook found that patients who required mechanical ventilation remained on these devices for an average of 11 days. Only 14% were successfully weaned from ventilators. The center convened a multidisciplinary team to improve the care of these patients. Specifically, new strategies included prophylaxis for thromboembolism and stress ulcers, electrolyte management, and assessing for sedation holidays. The clinical pharmacist on the team led the oversight of safe and appropriate medication use. These interventions, along with weaning strategies based on national guidelines, such as replacing synchronized intermittent mandatory ventilation with pressure support ventilation, contributed to positive outcomes. A comparison of pre- and post-intervention data revealed an increase in weaning rates from 14 to 25% and a decrease in average patient length of time on ventilators from 11.1 to 8.9 days. Mortality from any cause among this patient population decreased overall. For its innovative pharmacist-led multidisciplinary work in enhancing weaning of patients from mechanical ventilation, Kingsbrook Jewish Medical Center is being honored by the ASHP Foundation as a finalist for the 2010 Award for Excellence in Medication Use Safety. The 2010 recipient of the Award for Excellence in Medication Use Safety is the Medical University of South Carolina. Each year at MUSC, nearly 200 people undergo kidney transplant surgery. For patients and their families, the surgery means a new life.
Made me whole again.
For the medical team at MUSC, kidney transplant surgery presents a unique set of challenges.
A lot of what's happening with these patients post-transplant has to do with their medications. And unfortunately, a lot of these individuals have hypertension, diabetes, hyperlipidemia, multiple other comorbid disease states that need to be managed along with their kidney transplant itself.
The recipient has an intact immune system that without medications will universally reject the organs. So the success and the viability of organ transplantation is predicated on accurately, successfully, and safely taking medications to lower one's immune system. Therefore, the role of the pharmacist in this process is paramount.
The MUSC transplant team recently reviewed data from a 2-year period. They found that the hospital had high rates of readmission, and almost 1 in 3 patients stayed in the hospital for more than the optimum 3 days after surgery. A pharmacist-led team convened to tackle these issues.
What we came to realize is it was a complex problem, and there wasn't one in particular issue or one discipline that was at fault. This was a multidisciplinary issue.
Everybody has something to offer, and I think it's important for everybody to be heard.
One cause of the prolonged hospital stays was delayed availability of outpatient medications. The team recommended that prescriptions be filled at a pharmacy in the same building as the transplant center, rather than from the outpatient pharmacy 2 blocks away. They improved access to medication assistance programs and revised renal transplant protocols, order sets, and clinical pathways. Preventable readmissions were often due to adverse drug events, stemming from the patient education process. Pharmacists began to counsel patients before discharge and now review 100% of discharge orders. They also intensified their focus on outpatient education.
What time do you take your meds?
What shifted was the emphasis from the inpatient side to the outpatient side. Once we decreased our length of stay, then we felt that the education given in 2 days on the inpatient side was absolutely inadequate and had to be strengthened on the post-transplant side as the outpatient.
The team also established a diabetes management service to help with glucose control and continued its emphasis on education for patients and their caregivers during the first critical months after transplant.
When you see them in clinic, it's like a different person. They're in their own clothing, they've had a nice rest, and it's much easier to conduct good, solid medication education, and really education across the board.
Absolutely.
The results were dramatic. Medication errors and adverse drug reactions were down 40%. Acute rejection rates were reduced by 25%. Infection rates dropped by 10%. Delayed discharges were reduced by 14%. And the 7-day readmission rates were cut in half.
From A to Z, we looked at the problem, we looked at our outcomes, we looked at each aspect to improve the delivery of care to the patients, and the result is shorter length of stays, less errors, and truly a team approach.
These changes have resulted in improved care for patients and increased pharmacist accountability for patient care and outcomes.
We're not just dispensing drugs. These are the outcomes that we can affect. We can help improve our length of stay. We can help decrease our medication costs. We can help make sure we don't have readmissions. And so it's really created a very nice model for other services across our organization for how best practice really should be with pharmacists and patients and nurses and physicians.
For its pharmacist-led teamwork demonstrating systematic quality improvement in the care of kidney transplant patients, the Medical University of South Carolina is honored with the 2010 Award for Excellence in Medication Use Safety.
Quantity. Yeah.